Interpretation of laboratory results. This is Unit 2, Part 1, Hematology. As we have said before, hematology is the study of blood cells that are produced by the bone marrow. It includes white blood cells, red blood cells, and platelets. And we are concerned about their normal function, and we need to understand the basic function to be able to diagnose whenever there is a problem with any of those cells. Hematopoiesis is, by definition, the balance of three different things that happen in the bone marrow: cell production, cell differentiation, and self-development. The hematopoietic system includes different parts of the body depending on whether it is during gestation or after birth. During gestation, blood cells are produced by the fetus, first in the yolk sac, and that starts to happen very early in the pregnancy, from 2 to 8 weeks into the gestation. Then the liver and the spleen will take over the production of very immature, primitive blood cells, and then the bone marrow will take over after the 4th month, but it will not be the only organ producing blood cells until after birth. After birth, from birth to about 18 years of age, the bone marrow is the organ responsible for the production of blood cells, white blood cells, red blood cells, and platelets. And if something happens to the bone marrow, then the production of those blood cells will be compromised. As we age, the bone marrow will turn from being active, red, cell-producing bone marrow to becoming lipid, becoming adipose tissue, becoming inactive and unable to make blood cells. So we need healthy bone marrow to make those blood cells. The slide number 4 gives you a little bit of a schematic about how the cells become their final product, the white blood cells, red blood cells, or platelets, and how they differentiate. Let's say the white blood cells, how they differentiate between neutrophils and lymphocytes and monocytes, eos or basos. All those letters that you see in the slide, and this is just mostly FYI, this is just so you can understand the complexity of becoming a cell. All the cells become a specific product, but they all originate from a stem cell, from the pluripotential stem cell, where that cell can become any tissue, any cell, any specialized cell. And what will determine what it becomes is cytokines. This soluble messengers, these substances that activate some receptors on the cells or inactivate some receptors so that they can become the cell that they are meant to become, that they compromise into becoming. Slide number 5 introduces to the hematology department. In the introduction to the clinical lab science, we saw a little bit of what happens in the hematology department. And we know that it is a high volume area. We also know that sometimes it includes urinalysis and coagulation, but the actual hematology department is very, very busy running a lot of CBCs, a lot of complete blood counts. The complete blood counts, or the CBCs, are the #1 test ordered and run in the hematology department. And it is a screening test. It is a test that is commonly ordered, and it gives a lot of information to the doctor, to the physician, about what's going on in the patient. The CBC includes the number of white blood cells, red blood cells, and platelets that are present per microliter of blood in the patient. It also gives us the different types of white blood cells, so it differentiates the white blood cells that are present, either neutrophils, lymphocytes, monocytes, eosinophils, or basophils, and it tells us some characteristics of the red blood cells based on indices, based on numbers. Are the red blood cells too big? Are they too small? Do they have too much hemoglobin, or do they not have enough hemoglobin? And it also gives us some characteristics about platelets, whether they are functioning correctly or not. So The CBC is great for very specific information about those blood cells that are made in the bone marrow. Another test that is usually ordered and is performed quite a bit in the hematology department is the erythrocyte sedimentation rate test. And it has to do with inflammatory or infectious processes. The reticulocyte count or retic count is another routine test performed in the hematology department, and that is usually ordered if the doctor wants to see if the patient is reacting well to treatment for anemia. If the patient has been diagnosed with any type of anemia and they are receiving treatment, either iron or vitamin B12 or a unit of blood, they want to know whether the body, the bone marrow, is actually compensating, is trying to compensate and fix the anemic process. As we had mentioned before, coagulation tends to be part of the hematology department, and in the coagulation department, we will deal with the PT and INR, PTT and D-dimer. The next unit in part 2 of the unit 2 will deal directly with coagulation, so we have more to say about that. Slide number 6 gives us an idea. And this is just, you don't have to memorize these values. This just gives us an idea of the most acceptable reference ranges for the different parts of the CBC results. So depending on gender, male or female, depending on age, we might have a slightly different reference range. But remember, when you're trying to read results, you always refer to the reference range to make sure that your patient is within the acceptable range. If the patient's results are not within the acceptable range, then they will be flagged by the instrument. They'll have some kind of asterisk or some kind of notation or an arrow pointing that whether it's high or low. And we have to be very conscientious about noticing if the values are critical. So because if the values are critical, they should have been called in by the laboratory. So notation should have been noted somewhere in there that the results were called to the healthcare provider. Then we're going to start with a WBC count. So what are white blood cells? WBCs are white blood cells, and the white blood cell count that is included in the CBC, what it gives us is the number of white blood cells or leukocytes per volume of blood. And we usually use microliters. Some instruments might use a different unit, so that's why you have to always refer to the reference range. But the most acceptable by far is number of cells per microliter of blood. And we have here the normal range that is about 4.5 to 11.0 times 10 to the 3 per microliter, or 4,500 to 11,000 per microliter. And the white blood cells counts, or the leukocytes, can be further classified based on their characteristics and their function into 5 different types of white blood cells. We have them in the way they are here in order. The neutrophils are the first one. They go in percentages. So the most abundant cell in our blood are neutrophils, or segmented cells. And then percentage-wise, we'll see the lymphocytes. And then monocytes, eosinophils, and basophils. You also have a little in your PowerPoint, you have a picture of what they would look like. Just this basic characteristics of those 5 different types of white blood cells. And just so that you know, each one of these white blood cells, their general function is to get rid of any foreign substances that shouldn't be in the body. So any infectious organism, anything that breaks the first line of defense and gets into our body, then is going to activate these white blood cells to get rid of it. Most of them do their job by phagocytic function, but the lymphocytes are involved in the third line of defense, that is the production of immunoglobulins. We'll be talking about immunology in more details about what this is about, but you have to know, you have to be able to understand the basic function of each one of these 5 different white blood cells, and it's included in the slides that are coming up. Remember that the white blood cell differential will also include some semi-quantitative description of how the red blood cells look. We will have the numbers to compare them and to give us an idea about whether they are too big or too small or too pale or have too much hemoglobin. But it's good to correlate those numbers with the actual morphology of the red blood cells. And we also will have to correlate the platelet estimate. We want to know whether the count that was given by the instrument correlates with the platelets that we see on the peripheral slide. So this slide is very important. Slide number 8 is very important because it gives us just a basic function of white blood cells. And we need to know, to remember the basic function, and it is to recognize foreign agents and make sure that any foreign material will be destroyed or removed so that it doesn't cause harm to the host, so that it doesn't harm us. So leukocytes will be classified, like I said, as either granulocytes or agranulocytes. Granulocytes are the 3 different cells that have granules in the cytoplasm, and you can see them by the picture. And we have the neutrophils, the eosinophils, and the basophils are considered granulocytic cells. And the agranulocytic cells, the ones without granules, are considered the monocytes and the lymphocytes. Monocytes and macrophages are the same cell. The difference between the monocyte and a macrophage is that the monocytes are found in the peripheral blood and the macrophages are found in the tissues. So if you see on the column on the right, when we have the definition in the little explanation about the function of the monocytes, we have them as their function is phagocytosis, and we have them as fixed monocytes or as wandering monocytes or macrophages, because when they are in the tissue, they become, we call them macrophages. And when they are fixed, that means that they only stay in that organ, in that tissue, and they are making sure that any foreign particle that gets into those tissues is dealt with. And the wandering monocytes or the macrophages that are moving inside and out of different tissues, then when they are found in the blood, in circulation, then we just call them monocytes. Okay, so just so that you know where I'm coming from with this different terminology. So the function of the neutrophil, if I could make it easier for you guys, all of them will be phagocytosis except for lymphocytes. Okay, so phagocytic cells will be neutrophils, basophils, eosinophils, and monocytes. Granted, eosinophils and basophils have some other functions that make them a little different, but all of them have the ability, these 4 have the ability of engulfing and digesting any foreign particles, organisms or debris or anything like that. The lymphocytes are the only ones that are different. They are involved in specific immunity, and specific immunity has to do with the making of immunoglobulins. Again, that's coming up in another unit. Basophils are very, very good. You can see the picture as the very first cell on the pictures at the bottom, and they produce a lot of histamine. So all those granules that you see, all those very dark granules are full of histamine. And whenever we have allergies, whenever we have an allergic reaction and we have something that needs to be destroyed, those granules will be released. And usually the organisms are too sensible. They are very sensitive to those granules and they will die. So basophils will produce histamine. We see elevation of basophils in lead intoxication and in some leukemias. Eosinophils, they are very toxic to parasites, so they will be elevated in parasitic infections. They will try to engulf those parasites and get rid of them. And they are also related in allergic reactions. So in allergies, we will have elevated eosinophils. Slide number 9 tells us the difference between leukopenia, leukocytopenia, or leukopenia, and leukocytosis. Leukocytopenia or leukopenia is the medical term that we use to denote low numbers or decreased numbers of WBCs. Whenever a patient has low numbers of WBCs, the patients are very susceptible to infections. We do not want that. So they are usually, when a patient has leukocytopenia or leukopenia, it's because they are receiving some kind of medication or treatment that will actually kill those cells. There are some treatments like radiation, chemotherapy treatments for leukemias, or even certain medications that will lower the number of white blood cells, and that is not good to the patient because, again, they become very susceptible to all sorts of infections. Patients with autoimmune disorders, they tend also to become leukopenic or leukocytopenic, and again, it puts them at a disadvantage because they become very susceptible to infections. Leukocytosis is an increased number of white blood cells, and it can be a relative increase in WBCs or a neoplastic increase. We want to have a reactive leukocytosis if we have been exposed to an infectious agent. If we're having exposed to a fungus or to parasites or viruses or any bacteria, we want our WBCs to increase in number to fight off that organism. So we want it to be, our body to be reactive to the presence of a foreign agent. So that leukocytosis, when it's reactive, is considered normal. That is what we expect when the body has encountered some foreign agent. What we don't want is we don't want to have neoplastic leukocytosis, because that means that the bone marrow somehow got sick, that it's no longer working properly, and the cells that are being produced by the bone marrow are, like blobs of tissue that do not do their job and that just overcrowd the bone marrow, and that is usually known as leukemia, so cancer. So cancer of the bone marrow would be leukocytosis due to neoplastic growths. So slide number 10 gives us examples of reactive leukocytosis, and I have given you on one column we have leukocytosis with an increased number of lymphocytes. Whenever we see a WBC count that is elevated, and then we look at the differential, and we know we can see that the reason for the leukocytosis is because the lymphocytes are elevated. We usually correlate lymphocytosis with a viral infection. So patients that have like infectious mononucleosis or the kissing disease that is caused by the Epstein-Barr virus. Test question. I don't know whether it's a test question in this exam or it's a test question somewhere else, but you need to know the causative agent of infectious mononucleosis, because it's very, very common. It's usually transmitted through saliva. So even sharing a straw or a glass or kissing, right? The interchange of saliva, that's how the virus, transfers from one person to the other. It is highly contagious, so a lot of people end up with it. Because it's a viral infection, there's no treatment. There is just supportive treatment. The patient, depending if they get complications, then they will get supportive treatment, an IV, some medicine for the fever, and just bed rest so that they can, just let the body take over and let those lymphocytes take over and get rid of the virus. So leukocytosis with lymphocytosis, or an increased number of lymphocytes, is usually associated with viral diseases. And in the other column, we have some examples of leukocytosis that is caused by bacteria. So if there's a bacterial infection going on, then the neutrophils and sometimes to a lesser degrees, the monocytes will be elevated. So just knowing that there's leukocytosis will tell the doctor, okay, something is going on. Let's see whether there is that differential can give me some specifics, some guidelines as to what it is. Am I working with, should I worry about a bacterial infection? Then the neutrophils will be high. Am I worried about a viral infection? Then the lymphocytes will be high. What if it is a parasitic infection? Then the patient will have leukocytosis with increased EOS. So see that is why the differential part of the CBC is very important. There's a lot more to consider, but remember, this is just so that you can have an idea of what the doctor looks at or what we're supposed to pay attention when we get a CBC report. Slide number 11 gives us information about neoplastic leukocytosis. This is the abnormal reaction. This is a disease process associated with an increased number of white blood cells. Sadly, whenever there is leukemia or neoplastic leukocytosis, the red blood cells and the platelets will also be impaired. It will be affected just because the bone marrow is sick, is diseased. Okay, so whenever they are classifying the leukemias, when they are trying to figure out what it is, that not so much what the problem is, but if they know what the problem is or which cell is affected, they can target the chemotherapy. They can try to set the chemotherapy to affect that lineage, the cells that are sick, whether it's a monocytic leukemia or a lymphocytic leukemia or a myelogenous leukemia. Each one of those, if we know what the origin of the problem is, then the chemotherapy can be tailored to that. One of the things that they are always looking at, and you can see it in the differential, is the presence of very, very immature cells that are going to give an indication of the leukemia being an acute leukemia versus a chronic leukemia. Other things that differentiate acute leukemia versus chronic leukemia is how aggressive the leukemia is. So acute leukemias are usually rapid onset. The patient starts experiencing signs and symptoms. It almost seems like overnight. Patient is okay 1 week, and then the next they have high fever. They just don't feel well. They feel sick, and it's like just unexpectedly, right? And when there is acute leukemia, if the acute leukemia is not treated promptly, is not diagnosed, pretty aggressively and in a prompt manner, it tends to be fatal within months. Chronic leukemia, on the other hand, is usually very insidious. That is the word, the medical term they like to use, meaning that is slow, very slow to present itself. So the patient may be a little tired and maybe sometimes, just feel under the weather. Usually is not associated as a leukemia until they do some routine blood tests just to see why the patient feels off, a little sickly, and that is when usually comes out. So chronic leukemia is insidious. The life expectancy is a lot longer, and with treatment, it can really go into remission. So we want to just note have an idea of what acute leukemia versus chronic leukemia is. Again, remember that because the bone marrow is sick, even though a leukemia, the neoplastic leukocytosis associated with leukemia, is about white blood cells, the red blood cells and the platelets will also be affected. And what causes leukemia? Well, we really don't know. There's association of leukemia with some viruses. There is association with environmental factors. There's association with genetic predisposition. So there's a lot of different things that can make us unlucky enough to get leukemia. So Slide number 12 gives us just a little bit of information about one of the most common childhood leukemias that you might hear about. It is very common. And the good thing about this is that if caught early enough, acute lymphocytic leukemia, ALL, that is mainly childhood leukemia, is very treatable. Now is over 90% of the cases, when caught early enough, the patients will go into remission. And this is very good because this affects little kids. This is the one that can be diagnosed at 1 year of age to about 6, 7 years of age. It is the most common childhood leukemia around. And if the doctors know what to look for, it can have a good outcome. So what are some of the clinical features? Fever is very common in all the leukemias. Actually, all malignancies tend to show fever. There is paleness and fatigue. Remember that I told you that even though this is a problem with white blood cells, the red blood cells and the platelets are going to be affected. Whenever we don't have enough red blood cells or we don't have enough hemoglobin in the red blood cells, then we're not going to get oxygenated blood and we're going to feel tired, fatigued, we're going to be pale. And the bleeding and the purpura are tiny petechia, they are tiny bruises. Those are associated with the platelets, with a platelet or with the problems with a platelet. The bone and the joint pain have to do because there are so many cells present in the bone marrow that they push against the actual bone, and those little kids hurt. They literally hurt. They don't even want to be hugged because their bones hurt. They also can present with hepatosplenomegaly, that is an enlargement of the liver and the spleen, and in a lot of cases the patient will present lymphoadenopathy, and that is swollen lymph nodes throughout the body. So that is just some characteristics. There's more information to be gathered about this, but just remember, one of the most common childhood leukemias is acute lymphocytic leukemia. Lymphomas, the lymphomas are related with lymph nodes, especially lymph nodes, or any organ that is part of the that has function, that has close association with lymphocytic function, like the lymph nodes, the spleen, the thymus, or even the bone marrow. But they tend to be tumors. So because they are likely to present in the lymph nodes that are found in where the trunk of the body meets the extremities, like around the neck or in the armpits or in the groin area. That's where we tend to have a lot of lymph nodes. So there might be that swelling, that noted growth of those lymphoadenopathy on those patients, just like the picture says. So there are different types of lymphomas, and the main two branches are Hodgkin lymphoma versus non-Hodgkin lymphoma, and that differentiation will be done by pathology. And there are some characteristics that we can see in the blood smears, but they are just too specific. And remember that unless you are a laboratory tech, you will not be doing the differential, but you will get the results. As medical assistant or any other part of the medical team, you will have access to the results from the laboratory, and just so that you can have an idea what to look for. Slide number 13 starts with red blood cells. So the red blood cells are the cells that actually give the red color to our blood, because red blood cells are full of hemoglobin, and hemoglobin contains iron. And iron, the iron part of hemoglobin, is the one that attaches to oxygen. So the function of red blood cells is to transport oxygen to the tissues and pick up the CO2 so that it can be brought to the lungs and we can exhale it. So the function of red blood cells is gas movement. So deliver oxygen to the cells and pick up the CO2 and take it to the lungs so that we can exhale it. The red blood cells, they look like this. When I see them, I think of donuts. They do not have a hole though. They have, as you can see on the picture on the top, where it's a slide, it's a flat picture. That's how we look at when we stain them and we are looking at them under the microscope. But in real life, like the picture at the bottom on slide number 13, they do not have a hole. So they are not actual donuts. The red blood cells need to have extra body surface so that they can bend out of shape and go through every little capillary in the body so that they can deliver oxygen even to the most remote places. So that's why they have that disc shape. That's why they have that indentation in the center. And again, they are red because they are full of hemoglobin. Hemoglobin contains iron, and iron is the one that attaches to the oxygen or the CO2. They are usually alive, so their lifespan is about 120 days. So they live for quite a long time, unless there is a disease process that shortens their life. And they are usually about 7 microns in diameter. That is, if we're looking at them flat, then we have 7 microns in diameter from one edge to the other. But if we're looking at them as a 3D, in a 3D, like they are, they have body surface volume. They are between 80 and 95 femtoliters in volume. That's how they are. And we have a lot of them per microliter. We have millions of red blood cells per microliter. And just so that you can have an idea, a microliter is a millionth of a milliliter. And we have 1,000 milliliters in a liter, and we have about 5 liters of blood in our system. So we have billions, trillions of red blood cells in our body. And the functional part of the red blood cells happens because we have this substance called hemoglobin that contains iron, and iron is the one that will attach to oxygen and CO2. So you have a little, in slide number 14, you have a picture or a schematic of the hemoglobin molecule right there, so that you can have an idea of what it looks like inside the red blood cell. And we need to know if the red blood cells have enough hemoglobin, because their function is to oxygenate the blood. And if we don't have enough hemoglobin, then we're not going to have enough iron. And if we don't have enough iron, then we're not going to be delivering oxygen, especially to the brain. So every time a patient is anemic or they don't have enough red blood cells because they don't have enough hemoglobin and they don't have enough iron, patient is going to feel tired and fatigued and confused, all the signs and symptoms of anemia, because there's just enough. So how can we figure out how much hemoglobin we have? The instrument, part of the CBC, will tell us the amount of hemoglobin, and we also have the hematocrit. And you have probably, if you haven't done a hematocrit yet, I'm pretty sure you will do it, especially if you are in the medical assisting program, because this is very common. They will get a capillary tube, fill it up with blood, centrifuge it, and then they will measure in percentage how much or what percentage of the whole blood is packed cells, the red blood cells at the bottom, then how much is the buffy coat. The buffy coat contains the white blood cells and the platelets, and then the plasma on top. So in the picture in slide number 14, we have a tube of blood, a small tube of blood that is centrifuged and is separated into red blood cells at the bottom, then the buffy coat that contains the white blood cells and the platelets, and then the plasma on top. And that is what is considered normal. It's about 45% of the whole blood. A reduced hematocrit tells that the patient is very anemic, because anemia means that the patient doesn't have enough red blood cells, they don't have enough hemoglobin, they cannot carry a lot of oxygen, right? So we have anemia in the first tube after the normal, and then we have increased number of red blood cells in the last tube. And it's also bad to have that many red blood cells. And we're going to see some instances. The slides that are coming up will show us some instances of when we would see reduced hematocrit, or when we'll see it in increased hematocrit. Slide number 15 tells us about the red blood cell indices that are included, those values that are included in the CBC. They are super important because if the patient shows anemia, excuse me, if the patient shows anemia, decreased number of red blood cells, then the doctor wants to know, okay, if I look at the indices, if I look at the mean cell volume, or MCV, that will tell me whether the red blood cells are small or big. If I look at the mean cell hemoglobin, or MCH, or the mean cell hemoglobin concentration, MCHC, those two parameters, those two indices are going to tell us how much hemoglobin is present within the red blood cell. Okay, so it helps us that the red blood cells indices help us classify the type of anemia that is present. Do I have a microcytic anemia? How would I know that I have a microcytic anemia? Because I have low number of red blood cells that tells me that there is an anemia, but then the cells, the MCV, is smaller than it should be. The cells are smaller, less than 80 femtoliters, so that makes them microcytes. If the MCV is greater than 95, then I may have anemia with very big cells. And believe it or not, it is one of the first things the doctors look at when somebody presents with signs and symptoms of anemia. Why? Because the most common anemia is iron deficiency anemia, and that usually presents with low red blood cells because it's anemia, right? But the MCV is low, meaning the cells are microcytic. Another thing is that iron deficiency anemia also presents with very low hemoglobin. So the MCH and the MCHC are low. Iron deficiency anemia will show low red blood cells because it's an anemia, will show a low MCV, low MCH, and low MCHC. So iron deficiency anemia is characterized as microcytic hypochromic. Hypochromia is the medical term that we use to denote the amount of hemoglobin present in the red blood cells. Hypochromia, chromia is color, and the color of the red blood cells comes from the hemoglobin, and the hemoglobin contains the iron. So hypochromia is low color, and if there is low color of the red blood cells, that means that there is low hemoglobin and low iron. Hyperchromia, very few patients show hyperchromia. We really do not worry about hyperchromia in patients. We don't even use that term. If we see cells that seem to be loaded with hemoglobin, that's usually immature cells, and we call them polychromatophilic. But it's coming up in another slide. So disorders of red blood cells, we are going to be concerned with erythrocytosis, an increased level or increased number of red blood cells, and erythropenia or erythrocytopenia. The most common problem that we're going to be concerned with is erythrocytopenia. So erythrocytosis is an excess production of red blood cells, and it is also known as polycythemia. Polycythemia is a little bit confusing because poly means many, cyto is cell, emia is blood. So many cells in the blood. And by definition, polycythemia will affect white blood cells, red blood cells, and platelets. So when somebody has true polycythemia or polycythemia vera, then all the blood cells, the white blood cells, the red blood cells, and the platelets will be elevated. When we're talking about secondary polycythemia or relative polycythemia, that is usually because not so much because there is more red blood cells, but it usually has to do with decrease in plasma volume, like the patient is dehydrated. Okay. So we have here a Polycythemia Vera. It is an actual disease, and it is more common in Jewish people than anybody else. And even though these patients have a lot of cells, they have a lot of white blood cells, red blood cells, and platelets, they present the signs and symptoms of anemia. They have weakness and fatigue and joint pain. They feel sick because they have too many of everything. Secondary polycythemia is compensatory response to hypoxia. So if somebody smokes, all that extra monoxide that they are inhaling is going to lead to hypoxia. Hypoxia means low levels of oxygen. Patients that have any lung disorder, even asthma, can lead to this secondary polycythemia, meaning that the body has low oxygen levels, right? There's low oxygen in the body. The kidneys will sense that hypoxia. The kidneys will release a hormone called erythropoietin. And the erythropoietin, that hormone erythropoietin, is going to travel to the bone marrow and is going to tell the stem cells in the bone marrow that they need to become red blood cells because there is hypoxia. Very, very amazing process there. So we have secondary polycythemia, and again, patients present similar symptoms to those of anemia. And then we have relative polycythemia, and that is usually because of dehydration. It's not that we have extra red blood cells, we just don't have enough fluid there. Slide number 18, like I was telling you before, this is usually what is the most common. Erythropenia or erythrocytopenia is also known as anemia. That's how we pretty much know it, and is the common term. And what happens is there is an underlying cause. Something is happening, and that has led to the patient having too little hemoglobin, or that will lead to reduced number of red blood cells, and that will lead to the presence of symptoms, the shortness of breath, the paleness, dizziness, fatigue, confusion, heart palpitations, sweating. So there's a lot of signs and symptoms that can be present in anemia. The three main causes of anemia are because there is deficient of red blood cell production. The bone marrow is unable to make them because either the bone marrow is sick or does not have what it needs to make the red blood cells. It does not have the iron that needs to be present in the hemoglobin. So if there's not enough iron, then it cannot make hemoglobin, then it cannot make red blood cells. So deficient red blood cell production. Anemia can also be caused by blood loss, and that can be acute blood loss or hemorrhaging, or chronic blood loss. You're losing a little bit at a time, and that's usually associated with like very frequent nosebleeds or heavy menstrual flow. And then excessive blood destruction. Excessive blood destruction is seen in patients that have like sickle cell anemia, or that have malaria, a parasitic infection that affects the red blood cells. So any condition that leads to a hemolytic crisis will lead to anemia. So based on the morphology or the origin of the condition, that's how we classify the anemia. So we can either look at the morphology and say, okay, the cells are microcytic hypochromic, that's associated with iron deficiency, or we can just say the etiology or the origin is, well, it's iron deficiency, and because we have low levels of iron, and we are going to see the characteristic morphology will be microcytic hypochromic. Hemolytic anemias tend to lead to normocytic normochromic anemias. The cells that look normal, they have the normal color. It's just that they are being destroyed. So we just lose them. So those are hemolytic anemias. Again, the most common example here would be sickle cell anemia. In the chart that is associated with this unit, the homework that is associated will ask you to give characteristic about sickle cell anemia or a hemolytic anemia. And you can Google all that information very easily. And then megaloblastic anemia. Megalo means big, and blastic is formation. But this anemia, megaloblastic anemia, are the characteristic morphology of the cells are macrocytic. In megaloblastic anemias, the red blood cells are big, 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 and they are normal color. And when you see an anemia, low levels, low numbers of red blood cells, but the MCV is very high, then the doctor right away associates that with either vitamin B12 deficiency or folic acid deficiency. And how do they differentiate whether it's vitamin B12 or folic acid? Well, they order a chemistry test for a vitamin B12 level and a folic acid level. So that will give the doctor the ultimate diagnostic differentiating test. Then you have in slide number 19, you have classification of anemia based on their size. And I would recommend that you look at this chart. It gives you a lot of information and it helps you understand the possible etiology, the possible origin, and how the morphology of the red blood cells will be affected just based on one parameter on the CBC. So when the doctors see the CBC results, they look red blood cells and then they go to the indices, and right away they will say, okay, this patient is anemic. They have low red blood cells. They are going to have low hemoglobin, low hematocrit, and then I need I want to know, are they big or are they small? Are they microcytic cells or macrocytic cells? And then that can just, give them an idea of their test to order to confirm the diagnosis. If they see microcytic hypochromic anemia, they suspect iron deficiency. So what are they going to do? They can order some iron levels, right? Some ferritin levels, TIBC, some other tests to confirm the diagnosis. If they see that the patient has anemia and the MCV, that means cell volume, is big, so that you have macrocytic cells, then they want to see, is this because of vitamin B12 or is this folic acid? So they will order folic acid levels and vitamin B levels. If the patient has anemia, but the MCV is normal, then it's like, okay, what's going on here? Is there a hemolytic crisis going on? What could be the cause of that? Slide number 20, which is just pretty much FYI, just so that you can see how the morphology of the red blood cells would indicate different things. And we in the lab, we have to know. We spend a whole semester looking at this morphology just so that we can provide the most detail in the CBC so the doctor can have an idea of what is actually going on inside the patient. Thrombocytes, we're going to talk more about the thrombocytes or platelets. Thrombocytes is the fancy name, is the medical term for platelets. And the function of platelets is to form a platelet plug. So they will adhere and they will aggregate at the site of injury to form a platelet plug to prevent bleeding. One thing to remember is that we have a lot of platelets in circulation, but the spleen has a little bit, about a third of of whatever is in circulation. Another third of platelets will be stored in the spleen for cases of emergency. So if there's hemorrhaging, if the patient has just had surgery or has trauma, then if there's bleeding, if there's blood leaving the circulatory system, then the platelets will be released from the spleen so that they can get into circulation and they can go to the site of injury and make a platelet plug and try to prevent the blood from leaving the circulatory system. So they are pretty amazing, but we have a lot of information coming in the next unit. Then another high volume test in hematology is the SED rate, or erythrocyte sedimentation rate. And this is a non-specific test and not very sensitive either, but it is very commonly ordered. And it gives the clinician an idea about inflammation or infectious process that might be going on in the patient. Since it's not specific and is not very sensitive, we do have a lot more information, but it's not really relevant. You just need to remember that increased measurements, increased values are associated with inflammation or infection or both. And then the reticulocyte count, this is not done routinely, so meaning not every patient will have it, but it is ordered on patients that have received treatment for anemia. If the patient had experienced anemia and then they received treatment, the doctor will want to know how well they are recovering, how well they are responding to the treatment, and how better to know that as to see how well the bone marrow is working. So this is to see whether the hormone erythropoietin, is doing its job of telling the bone marrow to make more red blood cells. It is to see how the bone marrow is responding to anemia. So it's bone marrow's ability just to produce red blood cell for different things. Well, guys, see you next time. Good luck in hematology quiz.